Here, are you all well rested? Was that 15 minutes productive for everybody? I hope it was productive for you guys. All right. So our next topic will be for about macrocytic. Will be about macrocytic anemia. So macrocytic, anybody can tell me when you're going to characterize something as macrocytic? Cyrene, how would you characterize blood cells that are macrocytic? Cyrene, hey, Cyrene, hey girl, are you there? Cyrene, are you there? You're not here. All right, we'll call another person. Guan Yin, you appeared in my. How would you? Macrocytic. I'm asking macrocytic. More than 100. All right, thank you so much. All right, finish na, Cyrene. Anyway, we're gonna continue on with macrocytic anemia. So there's just two things that you need to remember for macrocytic anemia. It's folate deficiency and vitamin B12 deficiencies. All right. So let's talk about vitamin B12 deficiency. What autoimmune form of vitamin B12 deficiency? What is the autoimmune form of vitamin B12 deficiency? Well, when we're talking about vitamin B12 deficiency and autoimmune, automatically you have to think about pernicious anemia. What are the autoantibodies in this case? Antiparietal cells. All right? So pernicious anemia, antiparietal cells. Okay, so in terms of pathophysiology, what is the main difference between pernicious anemia and folate deficiency? Pernicious anemia is more of autoimmune, so it means that there's something there's attack from the person's own antibody producing cells, as opposed to folate deficiency, which is a dietary deficiency of folate. All right, okay. So will patient there is a question from one of my previous students. um, they asked me, a patient was diagnosed with pernicious anemia. His person is not that patient is not reacting to a green leafy vegetable diet, which is rich in vitamin B12 and folate. Why is that so? Well, because the problem is autoimmunity. The intrinsic factor from your parietal cells are not being used up by the body. Okay, so that's the main problem. So regardless of how much dietary folate and vitamin B12 the patient is taking, it still won't work. What's the best way? Injections of vitamin B12. Why will it work with injections? Because the only problem is the intrinsic factor in the blood, in the parietal cells. When it enters the blood, there is still intrinsic factor in the blood. So we might be able to relieve the patient of their anemia when we do injections of vitamin B12. But treatment is not our main concern as medical technologists. So we're gonna move on. Okay, so describe vitamin B12 deficiency. It's gonna be this long graph here, long chart here. So we're gonna start at the top. So for you guys to just remember the most important things that you need to do is that it will go here. We'll start here with vitamin B12. It will reach the stomach, and in the stomach there are what you call parietal cells. Okay, the parietal cells provide the intrinsic factor that will bind to vitamin B12, causing what we call a IF B12 binding. Okay? Or what we call the IF cobalamin bound cobalamin cobalamin structure. Okay? It goes to two things. It either gets to do two things. It gets absorbed into circulation and undergo and is used for DNA synthesis. Another way that happens is that it will bind to a methyl group floating in the bloodstream, and it will be released as dietary folate. It will bind to methyl, and it will become methylcobalamin, and then homocysteine, and then finally into methionine. Why did I put this last two here? Because this two will be very important later in the diagnosis of pernicious anemia versus folate deficiency. Okay? Homocysteine is important. Why? We have a disease that we've discussed that you will discuss when you talk about urine homocystinuria. Okay? Homocysteine is a problem with those patients. Okay? The enzyme that converts methylcobalamin to homocysteine is blocked. And I'm not going to talk about the specifics, but I just need you to remember the importance of homocysteine. All right? Now, what are the important blood chemistry findings in patients with vitamin B12 deficiency? Well, you're going to talk about homocysteine and MMA. What is MMA, you ask? That's methylmalonic acid. So there's an increase in homocysteine and MMA, or methylmalonic acid. So please remember, in vitamin B12 deficiency, these patients have an increase in homocysteine and MMA. Okay? Increased MMA in the bloodstream can result to neuropsychiatric symptoms. Why? MMA in the circulation is needed for MMA in the circulation is needed or is toxic to neural cells, and therefore they can result into neuropsychiatric disorders, hallucinations, and on a certain level, sometimes even uh, psychosis. All right. But again, as medical technologists, it's not important for you guys to talk about the symptomology of certain diseases. What we're looking more towards is the chemistries and clinical findings, laboratory findings rather. All right. How can a differential diagnosis be reached when we're talking about vitamin B12 and folate deficiency? Well, you have to check the MMA of patients. Okay? In patients with vitamin B12, MMA is high, and it is normal in patients with folate deficiency. Why? Because, as I've said, the problem is the structure here, the chart here. Vitamin B12 is not going into the body because the intrinsic factor is blocked by autoimmunity, right? Whilst in folate deficiency, the only problem is intake, correct? All right, let's move on. What's the test that is traditionally used to determine vitamin B12 malabsorption? We have what we call Schilling's test. And the principle of the test is that the patient ingests a what do you call this? Radioactive vitamin B12 or radioactive cobalamin dosage. And they, after 24 hours, the urine and the blood sample of the patient is tested for radioactivity. Now, is this dangerous? No. Okay. It's not dangerous. It's a non lethal dose of radiation. So don't worry. But if you're going to talk about Schilling's test, that's the test for vitamin B12 deficiency. All right. Malabsorption, rather. Now, since we're talking about since we're talking about megaloblastic anemia, we have to talk about non-megaloblastic anemias because megaloblastic anemia there is a presence of hypersegmented neutrophils. But in patients with non-megaloblastic macrocytic anemia, there is macrocytosis, but there is no hypersegmented neutrophils. Now, I have to ask a question because I've said something about hypersegmentation. How many lobulations would you consider normal for neutrophils? Um, what about Justin Yater? I like Justin Yater's name. It's very American. Justin, are you there, Justin? Oh, Justin is being quiet. All right, Justin. How many segments would you consider normal for a neutrophil? Okay, you're almost correct, but that's okay. 2 to 4. Um, yeah, 2 to 5, Justin. All right, 2 to 5. Now, you would consider a cell hypersegmented if it's more than 6. All right, and you will call it a Pelger-Hewitt anomaly if it's 2. All right, Pelger-Hewitt is characterized by the pince nez appearance. What's pince nez? It's actually a glass that's worn by clowns. Okay, so that's my interpretation of a clown, and that's pince nez. Okay, okay. So this is pince nez appearance. Hypersegmented 6. Okay, this is Pelger-Hewitt anomaly. All right, this is hypersegmentation 6. So that's my drawing of pince nez. So I don't know if you can remember, and hopefully you guys can understand where I'm coming from. I'm just trying to help you help you guys remember a little bit easier. All right, so that's non-megaloblastic and megaloblastic anemia. Okay, in what cases will we see patients with macrocytosis that is non-megaloblastic? Well, that's a very wonderful question because it's seen in patients with alcoholism, drugs, and liver disease. None of these have problems with DNA synthesis. So therefore, they are non-megaloblastic anemia with out hypersegmentation. So true or false? Patients with non-megaloblastic macrocytosis rarely experience signs of anemia. It's actually true. They are macrocytes, and the symptoms of anemia are less likely to be experienced in only in severe cases. Okay, so what would you say is so, sir? If you ask me, how would you consider something as a severe case? That's another good question. In chronic alcoholism and in chronic drug abuse, that's when you're going to experience when you're going to experience the signs and symptoms of non-megaloblastic macrocytosis. Okay, now common finding in patients with non-macrocytic non-megaloblastic macrocytosis, it's that vacuoles are present in the precursor cells. All right. Why are there vacuoles? Remember that these things can cause vacuolation. Proteins in liver disease, abnormal proteins in liver disease can appear. Alcohols can form vacuoles, and drugs can also form vacuoles. So don't forget about that one, all right? Because it's very important, especially in the exams. When for example, a patient is diagnosed with a particular liver disease. Um, let's say hepatocellular carcinoma. Uh, patient a patient's blood smear would look like what? They would ask you that kind of question. All right. All right. So now we're going to talk about aplastic anemia. Okay. So aplastic anemia is another important form of anemia, but it's actually a misnomer. And the reason being is that I wait, before we talk about a misnomer, we need to classify aplastic anemia into three groups. You have congenital, acquired, and iatrogenic. Now, we have congenital forms of aplastic anemia, and one of them is what you call diamond black fan anemia, which is also known as pure red cell aplasia. All right. Another one is what we call the Fanconi anemia. All right. Next one is the acquired form, and we're going to discuss it one by one later. Iatrogenic is another one, which is from intense chemotherapy. Okay, so as I mentioned before, we have diamond black fan and Fanconi anemia. Now, Fanconi anemia should never be confused with Fanconi syndrome. All right, Fanconi syndrome. I'm trying my hardest to write legibly here, guys. So please bear with me, okay? Okay. Fanconi syndrome is a problem with the proximal convoluted tubules. It's unable to do reabsorption. All right. As opposed to Fanconi anemia, the problem is all red cells are down. Hence the term pancytopenia. Okay? What is pancytopenia again, John Ilagan? John Ilagan, are you listening? What is pancytopenia, John Ilagan? I love the Kikai voice. What is pancytopenia? Okay. Google if you must. But people in the chat can participate. Pancytopenia. What particular blood cells? Yeah, what particular blood cells? And, and, meron pa ba? Wala na. Carry na girl, carry na. Chill. Okay lang yun. Chill. Chill ka lang. Tatlo lang ha. Pancytopenia. All right. Thank you, John Ilagan. All right, welcome. All right, so I will. I think people keep forgetting what pancytopenia is. Remember, guys, pancytopenia, you will encounter it several times during our discussion today. Pancytopenia. There is three words that you need to remember. Three words, three cells. Okay, pan is three, starts with three. Pancyto. All right, pancyto. Cyto means cells. Okay. Ania means low. Okay? Pan means all. Okay? That's why a person who is pansexual has sexual tendencies towards a lot of people. Okay? Whether it be male, female, or anybody in the rainbow. Okay? That's pansexual. So in this particular topic, this is pancytopenic. Then we're talking about the cells, all the cell types that you have for blood. All right. So please don't forget that this is going to be asked several. This is going to be mentioned several times. So Fanconi anemia is not actually a form of aplastic anemia, but rather a form of pancytopenia. Okay. Now, what are the congenital types of what congenital type of aplastic anemia is called as pure red cell aplasia? We already know. I've already mentioned it. It's diamond black fan anemia. Aplastic anemia is a misnomer for Fanconi anemia because it's known as a pancytopenic aplastic anemia. All right, a pancytopenic anemia. It's not aplastic anemia. All right. Summarize the difference between diamond black fan and Fanconi anemia. So there are several things that you need to consider. The definition is that it's a pure red cell aplasia. It's for black fan. For Fanconi anemia, it's inherited aplastic anemia or inherited pancytopenia, aplastic pancytopenia. Physical exam, tripharyngeal thumbs is present. Oh, I forgot to add, sorry. I'm gonna add something on the physical exam. So on the physical exam of patients with pancytopenia, of Fanconi anemia or Fanconi pancytopenia, we need to add this one, physical examination. It has radial bone anomalies. All right. It could be shorter, it could be larger, it doesn't matter. Usually it's the radial bone that is affected in these patients. Next, labs. We look at the laboratories. Decrease in RBC and reticulocyte counts. For the labs for Fanconi anemia, it's decreased in all blood cell counts. Okay? Why retics? Why is there no retics? Because it's, again, I've mentioned it earlier, it's pure red cell aplasia, meaning there's no erythropoiesis with regards to RBCs. Okay, so regardless of the stage, there is not going to be any red cell erythropoiesis, or what we call the RBC erythropoiesis. Okay? Onset, 8 years old and above. 8 years and above for onset for Fanconi anemia. And at birth, diamond black fan can immediately be seen, especially if the abnormality is present. Okay? What are the types of acquired aplastic anemia? What are the types of aplastic anemia? Acquired aplastic anemia. So we have sorry, excuse me. Idiopathic and secondary aplastic anemia. So idiopathic, what do you mean by idiopathic? How do we remember this? It is pathology for the idiots, meaning we don't know what the problem is. All right. Secondary aplastic anemia. So there is several causes, and this includes radiation, drugs, toxins, viruses, and immunological causes. So we're gonna talk about radiation first because this is the first and the last time I'm going to talk about it for you guys, because it's gonna be reappearing again, especially when we talk about leukemias. But this is the first and the last time I'm going to talk about radiation. What are we looking? What type of radiation are we talking about? Ionizing radiation. All right. So ionizing radiation. Okay. So what about ionizing radiation? Why does it cause aplastic anemia? Well, if you go back to your physics class, we have what we call a spectrum, a light spectrum. And this is the infrared region. This is the and visible region, and this is the ultraviolet region. All right. So why is this important? This one, the ones here in the visible region, this could include any of the colors of the rainbow, the Roy G. Biv colors that you might be expecting. Um, this one is the infrared region. The wavelength is longer. Okay. In the ultraviolets, the wavelength is much shorter. Okay. As the wavelength becomes shorter, it means the wavelengths, the peak and the throw is slow. The peak and the throw is shorter, which means that there is more vibrations that's being produced. Molecular vibrations. We're talking about molecular vibrations or atomic vibrations rather. Why is it important to know this, sir? Well, because this one has higher energy levels. Actually, X-rays and gamma rays belong to the UV region. Gamma rays. When these rays pass through the cells, they actually alter the molecular structure of DNA and RNA because of their high energy wavelengths. Therefore, therefore, it can alter the or it can cause mutations. It can damage the cells in the molecular level, it can damage the cells in the nuclear level. So the higher the energy rate, the more damage it can produce, it can cause the cell. Okay, so that's the reason why we talk about radiation all the time. And this is again the first and the last time we're going to talk about radiation, because I think a lot of the students are confused why radiation is considered ionizing, blah blah blah. Now, am I saying all of this is considered to be the only dangerous part, the UV ray? No, not saying all of it. I could say there are some cases that even in the visual spectra, it could be dangerous, and sometimes even infrared rays can cause a lot of problems. So I'm not saying that this is the only one that can cause cancer. What I'm saying is that based on the data, these forms of ultraviolet rays can cause cancer, or even in this case, leukemia and even aplastic anemia. All right. So antibiotic that can cause aplastic anemia. Can anybody answer? This is a bacteriology recall question. Antibiotic that can cause aplastic anemia. Anybody? Anybody from the group? You can type it on the chat. You can unmute yourself. You can basically say anything right now. Hello? Aplastic anemia is Aplastic anemia. Aplastic anemia. Drug that causes aplastic anemia. Chloramphenicol. Somebody answered. Jerisa Baltazar. Jerisa Baltazar. Hi, Jerisa. Welcome to the class. All right, Jerisa was the first one to answer. Give her a hands. Give her a big round of applause because the correct answer is chloramphenicol. All right, thank you, Jerisa. Thank you, Friendiza Ontok. And who else? Glyza La Chica. Thank you so much, guys. All right, what are the toxic chemicals that can cause aplastic anemia? So there's only three things that can there are three things that are known to cause aplastic anemia. Three chemicals that can cause aplastic anemia. We have arsenic, we have gold, and benzene. All right, arsenic, gold, and benzene. Sir, gold, are you sure? The liquid form of gold, guys, not the gold that you wear. Or the powdered gold, sorry. There's also the liquid and the powdered gold. Okay? Which viral infections can cause aplastic anemia? So there's four. You need to remember infectious mononucleosis, EBV, can cause a lot of hematologic disorders, hepatitis B, as well as HIV. And the most important one that you guys need to remember is parvovirus 19. All right. So parvovirus 19 is actually very important in this particular discussion because aside from being this one, I would consider this a high yield. This one could be a high yield question. All right. They might give you picornavirus in the choices. What else? Picorna, not retro. Coronavirus. Okay. Um, what else are the viruses that we can talk about? Coronavirus, Rabdivirus, and the Lassa virus. Which of the following can cause aplastic anemia? So those are the choices. Plus picornavirus, parvovirus 19. So please be mindful of these things because they might ask you about this in the board exams. Okay. Parvovirus is oftentimes the one that appears in board exams, so please be mindful, okay? Now, let's move on to immunologic mechanisms associated with aplastic anemia. Okay, so we have three. I'm sorry, we have one that we can talk about. This is actually T cell activation. When T cells are activated, specifically the cytotoxic T cells, they release cytokines. And these cytokines can actually attack the myeloid progenitor cells. All right. So those are the things that can cause aplastic anemia, I suppose. Now, true or false? Uh, True or false? Some pregnant patients can present aplastic anemia. The answer is true. It is reversible once the baby is formed. Now, it is another form of an idiopathic aplastic anemia, and nobody has been able to discuss have nobody has been able to answer that question. But the most common the very likely common cause is the hormonal changes. So there's a specific hormone in mothers that usually activate uh, uh, hematopoietic genes and deactivate it once a patient is pregnant, once the mother is pregnant. So that's the most likely culprit, although it hasn't been proven yet. But there are some cases, very rare cases, that pregnant women can exhibit aplastic anemia. Okay, now which patients are at risk for developing aplastic anemia or iatrogenic aplastic anemia? Patients who are taking in chemotherapy, intensive therapy, or aggressive chemotherapy. Actually, um, some people who undergo cancer treatments or even leukemia treatments, they die because of chemotherapy. And one of the main reasons they die is because they develop aplastic anemia, and the stem cells are no longer being able to cannot are being induced to stop producing red blood cells. But as that happens, the oxygen carrying capacity of the patient declines as well. So therefore, the patient suffers anemia, common causes of anemia. And with that particular regard, the cancer cells that the drugs are supposed to be killing is actually killing the patient. And I guess for me, it's much more important to have a different form of therapy in curing patients, because if you're trying to cure the patient, if you're trying to kill the cancer cells and at the same time you're killing the patient, it's not very productive or prudent to continue with the therapy. So sometimes patients opt to just cancel the or quit chemotherapy altogether. Okay, so that is the another. Oh, okay, another nice to know thing about aplastic anemia. Specifically, aplastic pancytopenia is often confused with what myelodysplasia disorder. That is what you call MDS. It's not Miriam Defensor Santiago, guys. Please, okay, it's actually myelodysplastic syndrome. All right, myelodysplastic syndrome can be differentiated with aplastic anemia with one thing: bone marrow aspirates. What's the difference? Pancytopenia with a hypocellular bone marrow is seen in patients with aplastic anemia because the stem cells are not producing anything in aplastic anemia. In MDS, there is pancytopenia in the blood smear, but there is a hypercellular bone marrow. That's the difference. The difference with myelodysplasic syndromes is that the blood cells are unable to exit the bone marrow. There's something wrong with the bone marrow. It's either myelofibrosis or essential thrombocytosis. That's the problem with these kinds of patients. All right. Now, our last topic is, I think, about autoimmune anemia for this particular slideshow. And after this one, we're going to have a. Is it okay if we get a 1 hour break? I'm not sure if you're. What time is it there in the Philippines? So just enough for lunch break, right? So after we finish this, I'm gonna give you guys a 1 hour break, and that will be for your one. That will be for your lunch break, and we're gonna continue on with leukemias. And after that, we're gonna talk about automation, and then we're going to talk about coagulation disorders. All right. Now, autoimmune hemolytic anemia. What causes red cell destruction in autoimmune hemolytic anemia? Basically, this is caused by autoantibodies or RBC autoantibodies to be specific. Okay, so I want to be specific, so I chose autoantibodies. Okay, so what is the general lab findings for patients with autoimmune anemias? So we're going to have the reverse of the other ones that we're talking about. So it's going to test positive with Coombs test, specifically with direct Coombs test. What is the difference between direct and indirect Coombs test? What we are detecting in direct Coombs test is the antibodies attached to the red cells. Okay? That's direct Coombs. I don't know why I draw. It looks like a seal. What I drew was actually looks like a seal. So I'm gonna try to draw better. All right. So in direct Coombs, what we're going to detect, this is your RBC, okay, and then it's attached with a lot of um, antibodies. All right. And direct Coombs, we add Coombs reagent. So it attacks the Coombs reagent actually attacks the attached RBCs. Okay, attached antibodies to the RBCs. So we're gonna change the color and huh. Okay, so you guys can get a visual representation. So what we're attacking in Coombs test is the RBC antibodies, autoantibodies. That's the reason why it's also known as the in vivo. All right, in vivo sensitization. It detects in vivo sensitization of RBCs. Okay, that's the general idea when we're talking about Coombs testing. And please don't forget about the blood smear. It's normocytic, normochromic. There's no problems with the RBC structure as well as the RB and the as well as the component structure of this particular anemia. Okay, there is also Rolu formation and agglutination of RBCs. So we mentioned last week that there's two types of abnormal distribution of cells. We have Rolu formation and agglutination. Why is there Rolu formation? There might be an increased plasma proteins, as in the case of patients who produce autoantibodies. There might be agglutination because it is an antibody directed towards our RBCs, and they might form a lattice. All right, there is an increased RBC count, reticulocyte count. Why is there an increased reticulocyte count? What is the purpose of reticulocyte count? Why are reticulocyte counts increased, by the way? The problem is that there is increased destruction of the cells, therefore there is an increased demand of oxygen supply. When there is an increased demand of oxygen supply, the body releases EPO. What is EPO, guys? EPO is erythropoietin. Erythropoietin comes from the kidneys. In the kidneys, there is a mechanism wherein if there is decreased oxygen saturation, EPO will be released by the kidneys, and that will activate your hematopoietic stem cells. In the hematopoietic stem cell line, it will start the last cell to be seen in the bone marrow is the reticulocyte, or what we call the polychromatophilic neutrophil, polychromatophilic normocyte. Okay, otherwise known as the reticulocyte count. That's the reason why there is increased reticulocyte count. Remember, in aplastic anemia, there is a decrease or there is no reticulocyte count at all. Why? Because although there is anemia, the body stem cells are not capable of cellular division or hematopoiesis because either they are damaged, for whatever reason. That's the problem with aplastic anemia. In this case, because there is increased demand for oxygen, the body normally activates its mechanisms. Why is there increased bilirubin? Because there is increased destruction of red blood cells. All right. What are the two types of autoimmune hemolytic anemia? So there's two types. It's actually alloimmune and autoimmune. Okay. So it could be alloimmune and autoimmune. What do we mean by alloimmune? Allo means same species, different type, different different pedigree or family. Okay, autoimmune, same same species, same organism. Okay, so what's the difference? It could belong to the same species. The antigens could belong to a same person, the same species, but they might change because there is another person that belongs to a different family. That's the reason why it's called alloimmune. All right. So a great example of this are your RBC antigens, your A and B antigens. That's the reason why I put here transfusion reactions. Okay. All right. Understood? Autoimmune and alloimmune. All right. What are the subtypes of autoimmune hemolytic anemia? So we have several subtypes of autoimmune hemolytic anemia, and we're going to discuss them one by one. So we have cold, warm, and paroxysmal nocturnal hemoglobinuria. Okay, so those are the three things that we're going to discuss. Those are just three of the things that we're going to discuss about hemolytic anemia. So let's talk about the most common one first: warm autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia occurs in 80 to 90% of cases. And it's very rare to have PCH. The rarest is actually PCH. Does anybody know what is PCH? I know I mentioned it before earlier, but I'm just checking if you guys can still can still follow me. What is PCH? Um, let's try asking who else is here. Jovel Hitosis. Jovel, what is PCH? All right, wonderful. Thank you so much. All right, give everybody a clap. Give Jovel a clap, guys. I'll give her a big round of applause. All right. Now, I'm gonna be quick here and summarize for you guys the differences between warm and cold autoimmune hemolytic anemias. So for warm, we have to look at three things: immunoglobulin class, primary effects. Sorry, uh, immunoglobulin class, primary cause, affects what population? Sorry, so it's about population or distribution, population distribution, and secondary causes. All right. So we're gonna start first with warm autoimmune hemolytic anemias. So for warm ones, we have IgG, of course, and because they're IgG, they will react at body temperature, 37 degrees Celsius. It can also bind to complement as well at that temperature. IgM is more of cold immunoglobulins, and it can react at 0 to 5 degrees Celsius. Now, distribution and population. Warm is commonly seen in children, while cold is commonly seen in adults. For secondary causes, autoimmune hemolytic anemia from warm autoantibodies can be from malignancies, autoimmunity, medications, and viruses in children. While for cold, we just put in infection. Why? We're going to talk about them one by one later, why it is important. All right? What form of malignancy is typically associated with autoimmune hemolytic anemia? Now, autoimmune hemolytic anemia is associated with um, three, sorry, three, three forms of cancers. We have Hodgkin's lymphoma, CLL, chronic lymphocytic leukemia, and of course, ovarian tumors. All right, CLL. Hodgkin's lymphoma, and ovarian tumors. We're going to talk about Hodgkin's lymphoma later. Uh, don't forget about that. Now I'm going to give you guys a review of how to detect Hodgkin's lymphoma in the body. All right. So in Hodgkin's lymphoma, we have what you call the Reed-Sternberg cells. Reed-Sternberg cells are actually what we call the owl's eye appearance. Okay, these are your Reed-Sternberg cells, and they can be seen in biopsies. Okay, sometimes they can be seen in the peripheral blood smear. Those are your um, Reed-Sternberg cells. Looks like Tweety, actually. It looks like Tweety, but whatever. All right, CLL. CLL is also an important one that we're going to talk about later because is associated with what they call smudge cells. Okay, so please don't forget these two cells. All right, now let's move on. Autoimmune hemolytic diseases associated with warm hemolytic anemia. We have systemic lupus erythematosus and ulcerative gastritis, not gastritic. It's gastritis. All right. So gastritis. Medications that can cause warm autoimmune hemolytic anemia. There is only one: alpha methyl-dopa. Okay, alpha methyl-dopa. We need to remember this. No, this isn't a high yield question. What you need to remember is Reed-Sternberg cell and the smudge cells. All right. Medications. We're done with that one. Infections. Infections that are linked with cold cold autoimmune hemolytic anemia. Please remember this one. This is considered again a high yield question in the medical laboratory scientist board exam because I will put a star on it so you guys will remember why it is important, because it can be asked in either bacteriology or even in your microbiology exam. All right. Why? Because Mycoplasma pneumoniae, infectious mononucleosis, and chickenpox are considered to be associated with cold autoimmune hemolytic anemia. Now, Please be mindful of infectious mononucleosis. I keep on repeating infectious mononucleosis. But what virus is the etiology is sorry is sorry the etiologic agent of infectious mononucleosis? Anybody can answer? What is the etiologic agent of infectious mononucleosis? Correct. Somebody answered already. Very quick. That's good. Thank you so much for answering very quickly. It is what? EBV. What is EBV? All right. Very good. Wonderful. Who was that? Ella? Is that you? Okay. I remember I told you guys last week when you're going to answer the question, you're supposed to say, "Hi, my name is Ella," and my answer is like this, right? That's our format. So I will sometimes I'm not looking at the chat. I'm not looking at the name of the person. I'm actually looking at the slideshows. All right. So please be careful when you're answering about when you're talking about autoimmune hemolytic anemias, because this is a high yield question according to some of my friends. What do I mean by high yield? They're often asked in the exams. So again, we're gonna put a star on it. Okay, we're gonna mark it. Okay, so it's Mycoplasma pneumoniae and pneumonia. It's supposed to be pneumoniae, and infectious mononucleosis caused by EBV, another also known as your Epstein-Barr virus and chickenpox. All right, rarest form of autoimmune hemolytic anemia is what we call your paroxysmal cold hemoglobinuria. Okay, and another term for this one is what you call the Donat-Landsteiner hemoglobinuria. Okay, the cause for this one is your Donat-Landsteiner antibodies. Okay, Donat-Landsteiner antibodies. How do we know? Why do we call it paroxysmal cold hemoglobinuria? Well, because when it's cold, IgG antibodies. Okay, please be mindful, of course, that IgG is the binding is the immunoglobulin class for Donat-Landsteiner antibodies. Okay, Donat-Landsteiner antibodies. Now, sir, I'm confused. You might be asking me, why IgG? I thought IgG binds at 37 degrees Celsius. That's the reason why I called it as a rare form of cold hemoglobinuria, because it is one of the few IgG based molecules or antibodies rather that can react at cold temperatures. What do you mean, sir? It can bind at in RBCs and can fix complements on RBCs at 37 degrees Celsius. At 30 degrees Celsius, at less than 37 degrees Celsius rather, or specifically at 0 to 5 degrees Celsius. So it is an abnormal form of immunoglobulin. But when it's warm, it can cause activation and it can cause hemolysis. That's the reason why it's called paroxysmal cold hemoglobinuria. Okay? Now, what infections are associated with PCH? Syphilis. What stage of syphilis are you talking about? Are we talking about? Or what types of syphilis are we talking about? Congenital syphilis, of course, and the tertiary syphilis. Okay? Clinical findings that are common in cold agglutinin disease. I don't know if it's important in the board exam, but hopefully it will be asked for you guys. Raynaud's phenomenon. Okay? See the appearance, guys? Extremities only. The parts of the body with the least amount of blood supply is actually the reason why there's no blood. So the reason why it's colored yellow or sometimes even pale is because the RBCs the RBCs clump here, and they can't pass anymore on the edges of the extremities. Okay, and with prolonged Raynaud's phenomenon, they become cyanotic, and I didn't show the picture, but it becomes necrotic as well. All right. So, um, spirocytes are often seen in one subtype of autoimmune hemolytic anemia, warm autoimmune hemolytic anemia. Okay, and that is the end of our part of the first part of our discussion. Okay, we're gonna come back later with leukemia, and if you have any questions, you can ask me now before we go to our 1 hour break. Do you guys have any questions for me? Anybody? Feeling ko si Guanyin may question sa akin. I have a feeling lang. Guanyin, do you have a question for me? Yeah, I will post it here, but you can't have a copy of it because I'll be asking questions that requires a poll. And I want you guys to participate in the poll for me. All right? Everybody will have 1 hour break. Anybody has any more questions before we go to a an exam before we go for our break? 1 hour break is okay. I think Miss Matulak is here, but I don't know if she's gonna react. Miss Matulak, can I give them 1 hour break if you don't mind? Oh, she's not here. I think she's quiet. But anyway, mm, oh yeah, she texted me privately. All right. Um, yeah. So that's it. We're gonna have an activity later. I might extend the. Is it okay for 1 hour 30 minutes? Would it be okay? Oh, excited na excited sila. 1 hour 30 minutes, but we're gonna have an activity later because I want you guys to participate, huh? I hope everybody gets to participate, and I'll be announcing the winner of my raffle slash uh, first placer. All right. So see you guys later after 1 hour and 30 minutes.